All right, good evening, everybody. I'd like to call the January 10th Community Mental Health Program and Budget Meeting to order. First order of business is the adoption of the agenda. Need a motion. Motion by Lou, support by Joan. All in favor signify by saying aye.
Aye.
All opposed? All right, motion passes. Before we move on to the hearing of the public, I just want to let everybody know there is cake in the corner. We were celebrating Macomb County's 200th birthday, which is actually on Monday. So feel free to help yourself to some cake and some coffee. With that being said, hearing of the public. I was trying to put you guys in a good mood in case anybody wanted to come up. Hearing of the... You have 5 minutes. Give us your name, address.
Hello, my name is Donna Conjemi. I live at 11235 Hemlock Drive in Sterling Heights, Michigan. In case anyone doesn't know me, I'm the president of AFSCME Local 411. I represent the employees in community mental health. And I am also, for anyone that doesn't know me, I'm also a therapist in community mental health. So community mental health is near and dear to my heart. I come up here tonight because I'm concerned, and I want to let you know that Jenny Joswiak, our union steward, wanted to be here today to speak also. Unfortunately, she slipped on the ice today and had to go to the clinic, and she was injured, so she wasn't able to make it here today. I wanted to clarify an email that was sent to her from a nurse in the AFSCME 411 bargaining unit at Specialized Residential Services. She stated, and it was sent to her on January the 5th, she stated there was a meeting in her office on December 20th with an administrator. And the nurses were told in this meeting that specialized residential services are closing and that consumers are being transitioned to other private providers. These nurses were told the county would try to avoid layoffs, and they were hoping the nurses could get jobs elsewhere in the county. Of course, this nurse was very unsettled and stated she would like to continue to work in Macomb County, but she did not want to work as a clerical or a custodian, as was suggested in the meeting, and she was asking the union steward for insight. Unfortunately, the union was not asked to attend this meeting, which probably should have been the proper thing that happened. Both Jenny and I are meeting with these nurses this Friday to clarify this issue. Jenny finally caught up with an administrator this morning before she fell, and she's been trying to speak to an administrator ever since she was informed of this on the 5th of January, since we came back from the Christmas break. And she was told this was just the first of a restructuring of all the directs to make them as efficient as possible. There are a number of issues I would like to bring forward regarding this. The union was never contacted regarding this meeting with our members. No one called me or my union steward and informed us administration was meeting with a group of our employees to let them know that 5 days before Christmas, they may lose their jobs. No one told us administration was going to interpret our contract to them. And Human Resources wasn't present. In addition, no one informed the union until today that there's a restructuring plan for other direct services. That sounds like privatization to me. I'm very concerned about this. There's not any communication between the union and administration in this department. That's a big concern to me, because if you're talking about jobs for my members, I'm very concerned about that. I should be a part of that from the beginning. That's what's happened with other departments, and that needs to happen, especially for my home department. And I'm here to express my concern, and I'd like to have something done about it. In addition, I'm going on record today to state that this union wants to be involved in any discussions that take place regarding any move towards authority if that becomes any discussion in the future. I worked extensively at Martha Teaberry when they moved to authority, and I want to be involved in that from day one. Thank you so much for your time this evening.
Thank you, Donna. Give Jenny our best. Hopefully she feels better after the fall. Anybody else from the public wishing to speak?
Good evening. My name is Kathleen Kuntz-Pilak. My address is 10165 St. John Drive, Algonac, Michigan. I am a vocational skill development provider for Macomb County Community Mental Health. And today I bring to the board, I have came before the board in the past. If you recall, on April 1st of 2017, I came before the board pertaining to a pending 2% budget cut from Macomb Oakland Regional Center and imploring the board to please not cut the providers anymore. We are your direct line. We are the backbone of services in the county. We provide the direct care support to the citizens of Macomb County. We cannot tolerate any additional cuts. That was the comments that I made April 1st of 2017, or excuse me, the February of 2017. So in April of 2017, Macomb County Community Mental Health decided that they would directly contract with the vocational skill development providers in the county. And at that point, we transitioned our services over through the help of Macomb Oakland Regional Center, transitioning all the authorizations. We still do receive a lot of support from Macomb Oakland Regional Center in writing the plans of service, and there seems to be a real good collaborative, cooperative relationship between Macomb Oakland and Macomb County CMH. But today I'm coming before you because the rates that have occurred since that have resulted in an overall 11% budget cut for creative empowerment opportunities. Now, our budget was based on the rates that we were being paid by Macomb Oakland Regional Center. So Macomb Oakland Regional Center for facility-based services were paying us a rate of $2.89. The new rate that we're being paid by Macomb CMH is $2.50. That is a 13.5% budget cut. Macomb Oakland Regional Center was paying us for community, taking individuals out into the greater community, $3. We are currently now being paid for that service $2.50. That is a 16.6% budget cut. Macomb Oakland, Macomb County CMH facility rate prior to 4/1 was $2.29. Our new rate is $2.50. So that actually is an increase of 9%. And then Macomb, our community rate, what used to be prior to 4/1 was $3.16. Today our rate is $2.50. So that's a 21% budget cut. So mathematically, if you add those together, overall it's 11% budget cut, which has resulted in $163,990 cut. Now, a nonprofit charity, to take that substantial amount of cut, it is extremely huge. At this point, we've exhausted the money that we have to be able to continue to provide supports and services. So if something doesn't occur and our rates don't get readjusted, we're going to end up having to start minimizing services to the citizens in Macomb County. With that being said, we also, when we were working with Macomb Oakland Regional Center, we were paid for transportation. We are no longer paid for transportation because it's rolled into our rate. So that's an additional like $35,000 of revenue that when we set our budget out at the beginning of 2017, that we were expecting that kind of revenue and basing it on just like any type of operation would. So I'm come before you today because as CMH has worked really, really hard in understanding and the rates and the adjustments, is that they came up what was called a weighted average, and that's the weighted average is that $2.50. But when you calculate how CEO has historically been operating with the funding from MORC and with the funding from Macomb County CMH, our weighted average should be $2.76. would be the weighted average, and that would be keeping us cost neutral. That would be keeping us, there would be no increase in revenue. We would just be status quo. And I come before you today to please consider looking at our rate. Once again, I came before you in October. I'm coming back. It's now January, and I'm asking you, please consider adjusting our rates to the $2.76. Is there any questions? I did it all in writing, so I do have, I don't know if it's appropriate to walk over to hand this in.
Sure.
And then you can just pass it on.
Yep, absolutely.
Well, thank you very much for your time. It is an honor and a privilege to service the residents and the citizens of Macomb County. I encourage each and every one of you, if you ever had the opportunity or time and you'd like to come out and see what your skill development and your vocational providers provide in the county, I welcome. Our doors are always open to come in and see the services that are being provided within our community centers and also within the greater community. Thank you for your time and consideration.
Thank you. Anyone else from the public wishing to speak? Anyone else? All right, seeing none, we'll close the hearing of the public and we will move on to 4A, a request to approve residential lease A. Who's here to discuss that one with us? TJ? Yeah. There's a bunch of them.
I'll make a motion to approve.
I'll second it.
Motion to approve by Commissioner Vosberg, second by Commissioner Flynn. All right, you guys take it away.
This residential lease is overall 4% increase, and it's based on increase in taxes and insurance, but the actual base rent stayed the same. And again, much like we have done in the past, we've capped the total taxes for the rest of the 5 years based on the lease that is before you.
If anybody has any questions, please raise your hands because the iPads aren't working correctly tonight. Any questions? All right, seeing none, we have motion and support. All in favor signify by saying aye.
Aye.
All opposed? Lou is opposed. Thanks, Lou.
Do you want to turn your mic on, Lou?
Lou, can you turn your microphone on?
Thank you. And I will vote no on any contract that doesn't publish the correct address. I think that pierces the veil of letting the public know that we're supposed to do it, and I don't understand why we're doing it, so.
Thank you, Lou. All right, that item passes. Next is residential lease B. Take a motion to approve.
I make a motion to approve.
Motion by Commissioner Flynn. Support?
Support.
Support by Commissioner Vosberg. Floor is
It's a
yours.
0.05 increase in monthly costs due to increase in taxes only. The base rent stayed the same, and the tax payments are also capped, much like we have done in the past. The last duration, 5 years ago, this lease was reduced by 11%.
Any questions on this one? Marilyn?
As I was reading through these leases, I observed that page 13, page 31, and page 57 are identical. They're supposed to be for 3 different houses, and it's telling us the same thing is wrong, and the landlord told us the same thing he's going to do to all 3 houses.
We don't have
The
same page numbers.
The landlord for the properties, I should note, A, B, C, and D are the same landlord.
It's the same landlord,
And-
it's different houses, isn't it?
Yeah.
Different houses, and he submitted a matrix that you're referring to that spelled out the different homes. It is the same page, but he has different homes spelled out within that matrix of his responsibility.
If you look at B, in the dark area of that attachment, that is the repairs only related to that particular home. I apologize, we should have wrote lease B right in the particular column. So only the column that has specifically darkened references that home. So when you see the next couple leases, each time you see a darkened box, those are the repairs.
Okay, thank you.
Joan?
Commissioner, I'm having a hard time hearing you. Can you speak in the mic?
Sure.
Yeah, both of you.
Yes, ma'am.
Just you.
How about you take it?
Thank you.
I'm a little louder than. Yep.
It'll move over.
Any other questions on lease B? All right, seeing none, we have a motion and support. All in favor signify by saying aye. Aye. All opposed? Commissioner Birdie? All right, next is residential lease C. Take a motion to approve.
Move to approve.
Motion by Marilyn,
Support.
support by Joan. Go ahead.
This particular lease represents a .03 increase in monthly costs due to increase in taxes only. The base rent stayed the same. Adjustments have been made to the taxes and capped for the next 5 years. And the last go-round, it was actually reduced by 11%.
Joan?
Through the chair, do we pay the taxes?
We do.
But we cap them, so the amount you
I
have
mean,
listed
why
there.
are we giving him an increase then
Oh, sorry, yes, sorry.
if we pay the taxes?
I'm sorry,
Oh.
Joan, can you say that again?
It's, you keep saying there's an increase in taxes.
Yes, we, that was a misspeak. We don't cap the taxes. It's a pass-through by CMH for the taxes, but we have begun to cap the insurance costs. The taxes rate increase at the rate of that the community puts on that home, and we do pick up that rate increase. We don't really have a choice or any leverage in that, but we did with the insurance rates, so we do cap the insurance rate.
Okay, thank you.
Kathy?
Just a clarification, we don't pay the taxes directly, we reimburse the,
That's
the
correct.
home-
Okay.
That's
the
correct.
landlord, right?
We
And
re-
sorry, and that's true with the insurance as well. That's a reimbursement cost as well.
They reimburse, we reimburse.
That's correct. When we establish the lease, we establish a base rate, the tax rate, and the insurance rate. On a yearly basis, by March 31st, the landlord is required to send us documentation for the taxes and the insurance, and we make those adjustments on a yearly basis.
Okay, thank you. Thank you, Madam Chair.
Any other questions? All right, seeing none, we have a motion and support. All in favor signify by saying aye. Aye. All opposed? Commissioner Birdie is opposed.
I'm opposed because the address is not published.
It's right here.
All right, next is residential lease D. I'll take a motion to approve.
I move, we approve.
Support.
Motion by Jones, support by Marilyn. Go ahead, guys.
This particular lease represents a .01 decrease in monthly expenses due to a decrease in insurance. The base rent stayed the same. Of course, we're capping the insurance, and last time this lease was reduced by 6%.
Any questions on lease D? All right, seeing none, we have a motion and support. All in favor signify by saying aye. Aye. All opposed?
I'm opposed because the address is not published.
All right, next is residential lease E. Take a motion to approve.
So moved.
Motion by Kathy,
Support.
support by Dr. O'Connell. Go ahead, guys.
It's a 1% increase in monthly cost, and it's due to an increase in taxes and in insurance. The base rent stayed the same. Of course, insurance was capped at the amount provided for the next 5 years, and during the last cycle, it was reduced by 11%.
Any questions? All right, seeing none, we have a motion and support. All in favor signify by saying aye. Aye. All opposed?
I'm
Commissioner Birdie.
opposed because the address is not published.
All right, next is residential lease F. I'll take a motion to approve.
I make a motion to approve.
Motion by Joan,
Support.
support by Marilyn. Go ahead.
That's one of our commercial leases.
Oh, it's the next one. We gotta do F still.
We're still on F.
Oh,
Not
I'm
quite
sorry.
there.
That's
I'm getting
okay.
excited.
I'm trying to move it
I just
along.
want to sit down.
So So this particular lease represented a 0.03% decrease in monthly costs due to a decrease in taxes. Base rent stayed the same, and of course, we're capping the monthly insurance for the 5-year period, and the last cycle it was reduced by 17%.
Any questions? All right, seeing none, we have a motion and support. All in favor signify by saying aye. Aye. All opposed?
I'm
Commissioner
opposed
Brady?
because the address is not published.
All right, next is item G, the commercial lease, the clubhouse. I'll take a motion to approve.
I'll make a motion to approve with discussion.
Motion by Joan. Support by Kathy. All righty.
I'm a representative. I'm a appointee of Mayor Fouts because the clubhouse is in Warren. So I said I act on the board. And we've been asking for him for how many years to do something. Now he finally is. And I want to bring up Bruce, Mr. Dunton. I want to see if he's satisfied with all that's going to be happening at Crossroads, if I can, Commissioner.
Is Bruce here?
He's the director. He's the director of Crossroads, and he does a tremendous job.
Hopefully we're not putting you on the spot too badly.
If I may first, Bruce. Sure.
Yep, go ahead, TJ.
The list that's before you, the punch, referred to as a punch list of the items that are going to be completed at the clubhouse, was an effort sitting down with Bruce and addressing some of those issues that have been longstanding concerns for him and the consumers in the clubhouse. And that discussion is the genesis of the list that is in front of you.
Bruce, there was talk about taking over the whole building. What happened to that discussion? Didn't they?
The front two areas of the building
Yeah.
are leased by different tenants, and I don't believe that there is any move at all of them vacating those two areas.
Well, is there any way we can get another sign out there advertising the clubhouse?
I know that we spoke to Mr. Cavalier about that, as that being part of the negotiation for the new lease.
There is a reference in there. I'm just trying to find where it references it.
was
Oh, that's right. We took it out.
No?
I traded the sign for
What?
a better improvement. All LED lighting throughout the entire clubhouse to reduce our energy costs as well.
Well, the money
And-
he
and the
gets every
cost-
month, he should be able to give us a sign.
The lighting costs, Joan, about $40,000. For me to put a sign up there is probably going to cost about $2,000 or $3,000. So I traded that sign and will incur that cost down the road.
And you're going to make sure he does all these?
It's my number one goal for 2018.
Good, because I'll check them. Thank you.
Any other questions? Comments? All right, seeing none, we have motion and support on the floor. All in favor signify by saying aye. Aye. All opposed?
I'm not opposed. I have a question, Mr. Chairman.
Okay, Lou.
Can you tell me why you published the correct address for this and not on the others?
Because it's Macomb.
It's a commercial building. We've
So what?
that the public.
If your theory that you presented for not publishing addresses on group homes was that consumers would be threatened if people knew where they were located, my God, you got a house full here. So I'm asking you why you publish the address here and you don't on group homes with the same philosophy.
Lou, John would like to answer that.
Thank you. I try only to ask good questions.
It's a good question. Our direction that we wanted to pursue was those of residential facilities and group homes. And so we moved in that direction, and it was supported by the board to continue to redact the names of the group homes. We did not include in that discussion redaction of our leased facilities.
But John, your solution to a non-existent problem is ridiculous. Group homes are not under duress. They're not being threatened. Redacting their address is inappropriate. And here you go with a residential day facility on this unit, and you publish the address, and you're asking me to believe that your program is consistent. It is not consistent.
I think where I live and where I work are two different things, and I like to protect my privacy where I live.
Well, that's where you live.
Mr. Chair?
Lou, Kathy Kathy?
Mr. Bird, you made it clear at the last meeting when we took a vote on it, and you made it clear with your votes now. To me, that's a board issue. The board made that decision. If you want that on another agenda for another meeting, I suppose we can bring that up again, but that was something that the majority of this board voted on. So in my opinion, you have to talk to the board members, but at another time. It's not on the agenda.
All right, that motion was approved. So we are moving on to H, agreement between Macomb County Community Mental Health and TBD Solutions. Thank you both.
Yep. Let me give you a background on this. When I developed the strategic plan for 2018, I brought before this board one of those items, which was to take a look at, simply put, without throwing a lot of words on it, the pros and the cons of Macomb County Community Mental Health as an authority. And so at that time, some asked, why was I doing so? Because I think it's necessary for us to do a more comprehensive assessment and evaluation on whether or not in the future marketplace, Macomb County Community Mental Health should be an authority or remain a community mental health services program. It's received a lot of backyard discussion off and on. It's never really come before the board for any affirmative action. I did put it in the strategic plan, and I'm moving forward with it quite readily for your consideration, but it's going to be very thoughtful, and it's also going to be very much in the control of the board. You can say stop tonight, you can say stop the next time we meet, you can say stop in the spring, you can say stop next fall. So the way we put this together, the way I put this proposal together before you, is that in 1997, this board asked, I believe, someone to do an investigation or a study on the strengths, the pros and cons of becoming a community mental health authority. And so we did that internally. It was a comprehensive report, 5, 6, 7 pages long, that spoke about what were those risks and those benefits, at that point in time. And now it's 20 years later. We have not done so in the last 20 years. So now we're here in 2018, 21 years later, and I think it's time that the board does another check. And I equated it last time with, having a checkup on your heart. Last time your heart was feeling pretty good, you got it checked out, and it was pretty good. Well, 20 years later, is your heart still good? And 20 years later, are you still in a good position to not evaluate yourself on whether or not there should be the pros and the cons, or what are the pros and the cons of authority? A lot has changed over the course of time. There's a lot that's changed at the state level, constantly changing at the federal level. And I even hear today through something President Trump indicated that he was going to do some other healthcare reform in the coming months. The marketplace has considerably changed over the course of time. The dollars aren't available that they used to. We used to be rich 20 years ago. I mean, we aren't rich anymore. We're struggling for every dime. And the service design has become much more challenged and considerably extensive. Before it was just like Medicaid and a lot of GF. Now you got Medicaid, you got Healthy Michigan Plan, you got My Marketplace coming into place. You have a number of different waivers that you never had before. You have less and less state dollars, more Medicaid dollars, or diminishing Medicaid dollars. So I really feel it's necessary and important for this board to just do a heart check and determine for your own knowledge base to be better informed, should we look at becoming an authority? But the very preliminary step here is to spend a little bit of money. And I'm only suggesting, I have before you a a statement of work by TBD Solutions. TBD Solutions is a provider that we've used a number of times, an agency that we've used a number of times. They produce pretty good results for us. I think we have a lot of confidence in them. It's a veteran is a co-owner, and another woman that we know in the agency or throughout the state is, they're co-partners in operating TBD Solutions. I've talked to them a few times. And so the way the statement of work is lined up, and it's always at the discretion of the board, the top end value of this statement of work would be $17,000. And you would not even expend those dollars until to the very end of 2017 or 2018. So this isn't a real quick move to authority and we're on to another roadshow. That's not the case. So if you turn to page 2 in the statement of work, and in the middle of the paragraph there, the way I've negotiated so far with TBD Solutions, the two CEOs there, is to prepare an initial dialogue for this board. Well, they will be here and present with you to present before you. And what they would do is they're going to spend 38 hours. So that's about $6,000. That's the initial ask. Well, the whole statement of work is the ask for tonight, but the initial money spent, and good money is well spent for someone who has the technical expertise that they have, would be around $6,200. That's 38 hours of their technical expertise to meet with myself as the executive director in forming an initial set of investigation areas, questions, and items for research. To engage in research and pursue surveys with other CMHSPs to understand rationales, barriers, satisfaction pertaining to their choices to remain either a department or their county to become a separate authority of the county. So we would maybe pick out on Genesee County, maybe Jackson Hillsdale's of interest to me. Washtenaw County would be an interest to me. Perhaps what's going on at the Lakeshore region to interview Jeff Brown would be a reason. Why is it that Chip Johnson at Manistee-Benzie hasn't moved to an authority? So that interviewing process would really be held by TBD Solutions. Then you would have differing viewpoints of different CEOs in boards that have either chose to go to authority or not go to authority. The rationale, was a good choice, bad choice, and that's the kind of information that we would bring back to you. And then based on the research and the surveys, develop talking points in a white paper for a presentation back to this CMH board to solicit your feedback on the direction of any additional effort. So all they're going to do is a bunch of interviewing and fact-finding, and that we'll be able to put a white paper together to do a PowerPoint presentation and give it back to you. And at the board's discretion and direction, conduct any additional investigation regarding the pro or the con of becoming an authority. That's where the phase 1 would be. And if you turn further back on the last page, I don't know what page it is, page 8, this is going to take a while to do this. I'm not trying to rush this through. It's going to take a while. But in January of 2018, I'm not going to repeat what I just spoke about. But in the first 2 cells, they're kind of colorful, a little chart that goes across there. Sometime between April and June of this year, which is a few months out, that TBD Solutions and myself will report back to this board the findings of those surveys. And so you'll have a better understanding of what the other CMHSP directors and boards have realized relative to their initial effort to move to authority or not move to authority. And then at that point in time, it's at the board's discretion on whether or not you want to let an RFP. So if you're going to let a request for proposals, because you need to do a pretty comprehensive assessment of this, it would be at your discretion to let an RFP, and then TBD Solutions is suggesting here in their work statement or statement of work that they would work with our business management team to develop the construct for the RFP. You may want to solicit an RFP from a legal firm that would be able to put you on path of all the questions that this board would need to know at some point in time if they were to move to authority from a legal perspective, that you'd be very well understood, very well read, what it would take from a legal perspective to become an authority, or from a political perspective, what you may need to do, or a statutory perspective to become an authority. You may also want 2 RFPs, one from a legal company, and maybe someone from like Health Management Associates, who's an expert in acquisitions and mergers and those types of things. And then HMA, Health Management Associates, may be able to, in their RFP, will write the RFP, and they would come back and say, well, you need to consider human resources and the cost for human resources. You'll need to consider legal, because we don't have legal of our own. You need the cost for legal. You would need to consider paying checks, because we don't write any checks and those types of finances. They may say you need to take a look at and do a comprehensive assessment, or they'll be able to tell you what it would take if you move from an authority. I don't have the knowledge base, but what would it take from someone who does have that expertise? If you went from an authority, what about all the employees? What happens to them? What happens to their pensions? Do you leave the pensions with the county? Is there an opportunity to transfer those pensions to an authority? How do you keep the consumer or the employees whole? And so you potentially get 2 RFPs that are written, and so then by the end of October or September, we let the RFP. And then I would imagine that process is probably going to take 90 days. And then when you get, what you'll get back is the proposals. And in those proposals, what you're going to have is a pretty comprehensive assessment. I imagine it would be a deep read of here's all the things that you need to consider to stay or to become an authority, or here are all the things that you may want to consider, the risk and the benefit of continuing to become or continue to be a community mental health agency. But I would suspect when the RFP comes back and the proposals come back, they'll be so comprehensive that you really won't have to ask any questions. And it may be black and white that we absolutely need to move in this direction, or we absolutely need to move in this direction, or we don't need to do anything. But it wouldn't be until probably a year from now that we would all be educated well enough through this RFP process to decide we're good, just stay where we're at, or let's move to an authority. But it would take a year of fact-finding before we could get to that. And that's what this is. And I indicated you're throwing around $17,000 out now. And if you wanted to stop it, in the spring and just commit $6,000, you can do that too.
All right, you need a motion and support, and then we can ask questions.
I'll make the motion.
Motion by Joan,
I'll support it.
support by Kathy.
With the question,
Kathy, did you have?
I do, but you
Kath-
can, the maker can ask first.
Okay, Joan and then Kathy.
I thought, I know we should look into it. I think it's a good idea. Not saying we're going to do it, but I thought the county commissioners had the last say on us becoming an authority.
That'd be part of what you will realize in the way of the due process, but the county commissioners do have to pass a binding resolution to do that. That'd be one of the steps. They'd have to have public hearings and other things.
And the county executive, he has no say, just the commission.
I don't want to answer all those questions now. I do recall from reading the mental health code that it would have to be a binding resolution by the Board of Commissioners.
Okay, thank you.
Kathy?
I was going to bring up the same issue. First of all, I support this motion because I think it is time that we take another look at it again. And because this board is more familiar with it, we're the ones to start it out. I do think at some point, depending on how far we get into this, the Board of Commissioners might need to be one of the partners or people at the table with the discussions as well. But I support this. Thank you.
Nick and then Brian?
Yeah, Mr. Chairman, I'm opposed to this resolution for a couple of reasons. First off, I think spending money, even though it's only $17,000, on this exploratory program is unnecessary. We have the internal, for the limited amount of information that we're acquiring under the contract as I read it, we could do this in-house at no cost. And I realize the administration is strained, but I think that that's such a small amount of information, it's inappropriate to spend that money when we're cutting services. Secondly, there's a provision in this contract, and I don't know if you're familiar with it or if it's just a mistake or an error, that allows the administration and the contractor to extend and expand the contract beyond the $17,000 and beyond the issues involved without board approval. It delegates that directly to the administration. And I think that's a serious error, just from a policy perspective on any type of contract, to say we're going to spend $17,000 and say, but the director and the contractor can agree to spend $10 million. Not that you would necessarily do that, without board approval is a mistake, so I think the contract is poorly drafted. Thirdly, we've done this type of study before. Now, I've been involved with movements of CMHSPs and PIHPs to authority status, both the Detroit-Wayne effort and the Genesee County effort. We supported one, we opposed another, and both of them came down to the retirement issue. The arguments that you've heard are correct. This board can't create itself as an authority. It can make a recommendation to that effect to the Board of Commissioners, but the Mental Health Code is very clear. The authority lies with the county to determine whether or not to run a CMHSP through an agency or an authority. So I think it's a mistake to do this in this fashion. Secondly, the retirement issue you raised is a very serious one. Was the stumbling block in Detroit-Wayne, was not the stumbling block, was worked out fine in Genesee County. But what controls, and we found this out when Kathy, I think, was on the Board of Commissioners, maybe Joan was as well, when we moved the Martha Teaberry from direct county agency to the Social Service Board, is that what controls on the retirement issue is the retirement ordinance. And so you need to have an amendment to the retirement ordinance, which is beyond our authority. In Wayne County, the Board of Commissioners committed to make that change and then failed to, and consequently the employees were not held whole. They were frozen in their retirement and forced into a 401k plan before the Detroit Authority. That's essentially the dollars that were ultimately used to allow them to pay the direct care workers, which is an equally valuable issue, the additional $2 per hour. So for all those reasons, I think this is premature. I think the discussions need to be held internally before we start spending money, and I'm opposed to the proposal.
Brian?
If my memory is wrong, correct me, but many times we've had discussion, and every time the discussion came up, in just discussion, was the fact we'd have to commit to buying all the properties. And there was no financial means at all to buying all the properties. So I'm kind of confused to why we would be spending money to go out and do a survey on this when we know that we absolutely do not have the financial ability to buy all the properties.
If I can comment, it gives you the opportunity to hold property and own property. It doesn't mandate you to purchase all those properties. Just if you want to, just by example, in Wayne County and Oakland County, they work with Community Housing Network, and Community Housing Network comes across properties that they turn into housing opportunities, assisted housing for people who have mental illness. And so there's some type of collaboration between Community Housing Network, and Oakland County eventually owns the property. But if this board, if we ever got to that point of authority, if this board wanted to hold property and own property, it could do so. It would not mandate that you have to purchase all the group homes and all of your commercial leases. That's not what that's not what I'm saying.
But if my memory serves me correct, I mean, the discussion was based, at the time we had the discussion, was Oakland County, that they literally had to go out and they bought all the properties up to become an authority. So, no?
I don't think so. I don't have that recollection.
That's how I understood it. So, all right, I'm mistaken on it, because that's my understanding was with they had to take control of the properties, and that's what's the difference between me and where we're at. They own the properties, we don't.
Mm-hmm.
Okay. Okay. All right. Thank you.
Lou?
In reality, I'm not comfortable with this proposal. I'm not uncomfortable with the fact of taking a look again at whether or not we should pursue or look at authority status. In some sense, that makes some sense. But hiring a firm for $18,000 from the western part of the state to tell us what's going on in Macomb County seems ridiculous to me when we're cutting services to consumers And we're fully able, in my opinion, to do that initial stage inside of our own operation. Pat Jens headed up the last survey when Don Hapkirk was CEO, the one that you're referring to in what, 2007 or 97? What was the year? Pat headed it up and was very involved in it, and I'm sure that she could provide some initiative there. For your recollection, the county's deposit of monies to our operation annually is at the lowest level it's ever been. And that has to be one of the primary factors when you consider the factor of authority status, because it freezes that amount of contribution in perpetuity. And that's the base amount of money that you need to operate going forward if you choose an authority status. Grand Rapids recently just laid off some personnel for cutbacks. Jeff Jones's operation is $23 million in the hole. These are very serious economic times, and spending $18,000 to come across what we should know of our own operation initially seems to me not only to be redundant, but a waste of $18,000. I'm saying that if you want to pursue it, pursuing it internally is what I would support and what would make sense to me, but not going forward with this contract. I think it's inappropriate.
No, I appreciate the opinions of the board. I think I bring the recommendation to you for your vote. I think it's opportunity, and it shouldn't be perceived as a threat. I think once you get the white paper and the presentation that would be provided by TBD Solutions to this board, I think you'll appreciate the $6,000 that you spent. If the board chooses not to go that direction, then I would certainly take your directive and do what we can ourselves internally.
Any other, Joan?
Through the chair to John. So you said 600 till what time? What date then?
The
6,000?
The initial 38 hours is right around $6,240 off the top of my head. And then that board, and if you would, the board would, or the TBD Solutions would do a PowerPoint presentation and present their findings back to this board.
And how long ago did we do this? You recall?
1997.
1997?
Yes.
Well, I think it's time we get up to date with what's going on in the world. I approve this.
Brian?
There's no reason why we can't do this internally?
We could do the interviewing, and I'll be honest with you, and I've been honest with you, nothing other than that. We could do the interviewing, and what TBD would be doing on the first, 3 months of this project. If I wanted to go out and interview all these CEOs that I just talked about, I think that, I could do that. Pat could do that. We could draw the relevant questions, and we could bring those findings back to you. To be able to write the RFP, I don't think that we have the understanding of the construct that you would need to write in the RFP to be able to ask the people who are going to submit proposals to give you the information that you're going to need. Because I wouldn't know how to ask the question, give me an analysis on what the preservation of the pension plans would be, or how we'd be able to, create opportunity to work with the county or move to an authority on. I wouldn't even be able to ask the question. And I think TBD Solutions would be able to help write the RFP as well as be able to disseminate the RFP and make sure it gets into the hands of people who are potential bidders. So the latter part of that certainly needs support from an outside firm. But otherwise, you write an RFP, and then people who have the proposals are going to scratch their head and say, what are they really asking here? And I think that needs to be a pretty thorough request for proposals. So it gives the bidder a clear understanding of what they're supposed to be bidding on. But if we did it internally, it's probably going to cost us $6,000 or more. I mean, when we talk about contractors that we have, we won't name anybody in the audience, but we talk about contractors, my own time, even though that's fixed costs, it'll cost us as much as $6,000 or more. So I don't want to try to be impartial here and sell it, other than I think my recommendation stands is, I think it's opportunity, great opportunity. Call me out and call me wrong in April or May and say, boy, was that a waste of money, after you've seen the TBD Solutions presentation, because I don't think it will be. I think you'll say, this is really good stuff. You may still say at that point in time, given all that, we don't want to pursue it in RFP. But I think it's worthy of the initial $6,200 investment. So.
Marilyn?
I think there's a lot to be said for having a neutral, impartial party doing this research and presenting the facts. I think that's a benefit.
Any other questions or comments? All right, we have a motion and support on the floor. All in favor signify by saying aye. Aye. All opposed?
No.
All right, let's do a roll call. We'll start with Joan.
Yes.
Joan is a yes. Kathy? Yes. Yes. Marilyn?
Yes.
Yes. Myself? Yes. Chris?
No.
Is a no? Brian?
No.
No?
No.
Lou? No? Nick? No. 4 to 4? Of course it is.
Well, Mr. Chairman, just if I could point of order.
Nick.
4 to 4 obviously defeats the motion, but 5 to 4 defeats the motion because under our rules, you need a majority of the committee to act.
Correct.
So you need 7 votes.
Mr. Chair, can we bring this back to vote on it when we have more commissioners in the room?
To full board.
Yes. I'd like
Can-
to make a motion
Thank you, Joan.
to
Is there-
bring item H back when we have a full board. We're missing 4.
We're missing 4.
Missing 4 members.
Is there support for that motion?
Yeah, I'll support it.
All right. Support from Chris. All in favor signify by
Mr.
saying.
Chairman,
Nick?
Just a question here.
Sure.
This committee is charged with making recommendations to the full board. It has defeated the recommendation. To then send it to the full board seems to me a dereliction of our own duty. We can bring it back to this committee anytime for discussions, and if votes change, votes change.
Mm-hmm.
But I think to refer it to the full board, and I'm not sure I know for sure what
I
Joan's
didn't-
motion is. I mean, maybe I'm misunderstanding your
Yes.
motion.
Joan, go ahead.
I'm sorry. I didn't mean to the full board. I meant bring it back to program and budget when we have a full membership here.
I quite frankly don't think you even need a motion for that. The chair.
The chair
we
can
we
bring any
we
item
can
up.
The chair can schedule it, or we can reconsider the vote anytime.
Right.
So,
Oh,
Right.
reconsider.
so I don't have a problem with this committee reconsidering it.
Yeah. It does not pass. We will not be bringing it up at full board. I'll take a look at it and see if we're going to bring it up at a future committee meeting.
Thank you.
All right, next is item I, contract approval request with Mariah Inc., DBA Eisenhower Center for the provision of adult residential and clinical services effective 1/1/18 to 9/30/18. Take a motion to approve. Motion by Kathy. Support from Joan, I think. Joan, go ahead.
Good evening. This is a contract that I did bring a single case agreement before you last month. This is a new provider that we're bringing on, residential provider for adults. And they are located in Ann Arbor. They do all-inclusive services, case management, psychiatric, nursing, skill building, community living supports. They currently are serving 1 individual for us, and we would like the opportunity to serve more with them, so we are looking to fully contract with them. Is there any specific questions that I can answer for you?
Nick and then Brian.
Yeah, I always get confused by how we do these things. Why aren't they just being added to the provider panel?
That's what I'm asking you to do, is to
Well-
add them to the panel.
Well, why do we get, I mean, most of the time we get like a chunk, or we don't get individuals, and I don't know why we're doing one here and one there rather than,
A chunk of providers?
well, we
Or-
approved the provider panel already. And it's your suggestion that we need additional people on the provider panel?
Additional providers, correct.
Additional providers?
Correct.
And my understanding is there's a lot of folks who have been sort of waiting in the wings. At least I've been contacted by some, and I'm not vouching for them or opposing them, supporting them, or anything because I don't know enough about them. I think you all should vet them before we consider them. But why this one and why not the others who have applied for status on the provider list?
Good question. When we are going to contract with the provider, we do a pre-delegation audit. And so this provider has gone through that process, and we feel that the quality of services they can deliver is something that we would support. And then the other providers that we're going to bring to you later this month have gone through that same process, and we feel secure in proving that they would provide the level of care that we would want. So those that perhaps would like to be on panel but have not been brought in front of you for that same recommendation have not met those qualifications.
Yet what I've been told by some providers is that we're vetted and we're okay, and they said they were going to add us, and then they told us and said, no, you have to wait until we issue an RFP. And there was an RFP coming, I was told, I think John told me, or maybe you did, that there was an RFP coming. So why does this one get pulled out, and why aren't we looking? If we're doing an RFP, why do some people get treated one way and other people get treated another? I just don't. I'm not knocking these folks. I mean,
This
they're
provider-
relatively new, at least according to what they've indicated, or at least from what I saw. Maybe I'm wrong, but it seems to me we need some consistency in the manner in which we develop our provider panel, and to have one come separate and then tell others, no, you got to wait until there's an RFP, just seems to me fundamentally unfair.
Depending on the service line, we might bring a provider on if there's an urgent or emergent need. This provider specifically will serve those with an IDD diagnosis, and we do not have the residential network to serve that population at the demand that we need it. The past year, we've experienced a lot of folks in hospitals or being kind of shuffled around through our residential network and not have a consistent level of service. And so we've been seeking residential providers who are able to support those individuals, and this provider is one that is able to do that. We did do a residential RFP in 2017, and they meet those qualifications. So we are going to release some more RFPs. We brought requests to you last month to
Right.
release those, and so I know there are some providers interested in joining the panel, and they're not that's not residential related, and so those RFPs will come out this year, and those providers will have an opportunity to bid to be on the panel at that time.
So you're saying this one was kind of pulled out of the RFP process because we're facing an emergency situation in terms of needs for additional providers?
We had already done the residential RFP. Did you want to speak, Jim?
I
Go
just
ahead,
wanted to
Jim.
mention, in this particular case, we did a single case agreement on, in order to get a consumer out of the hospital, and this is a provider that will service particularly challenging IDD consumers. We don't have a lot of providers on our panel that can really handle consumers that are acute and behavioral within our panel. And so we want to try to support that. And in this particular case, we had a consumer that had that need, that had been in the hospital for a long time. We had to act quickly in order to get that consumer placed with a provider. So we executed the single case agreement, and now we want to expand that and be able to use this provider for more consumers like that, which we seem to have a lot more coming through the door these days.
Nick, you all set?
Good.
John?
If I can comment, generally, practice across the board, and our procurement policy does, we bring them all to you in one batch, okay? If we and in the procurement policy, if there's an emergency or an urgency of need, then we'll bring to you a individual provider contract. And I think that's what you're seeing here, and you see it periodically. You know, like I always say, OTPT, speech language. Anybody who's out there that wants to do that, we'll bring you on panel, because we don't have, we could always use more OTPT, speech language people. Do we need more residential providers? If we're for our peanut, then we're going to need more. We don't need more CLS providers, maybe. Or I shouldn't be saying which ones we do and don't need right now. But in this particular case, as Christine and Jim conveyed, we have more and more intellectually developmentally disabled consumers showing up in an emergency room, dropped off, and now they're there for 40, 60 days, and we're trying to get them out. And so the reason that's brought to you is not to wait for an RFP process, but we need someone who has that expertise in IDD residential services. So it's kind of on an urgent basis. That's why you're seeing this one differently.
Brian?
Pretty much answer the questions that I have, but the one concern I have, and being that you're stating that these consumers are being dropped off at the hospital, I'm assuming they have no family contact or a guardian that comes sees them. My concern was the locations and the distance from Macomb County. If I had a family member, the distance to travel to go see the family member. And because, I mean, the closest one I think that's in here is Ann Arbor, which is 40 miles away, 50 miles away.
Often that is the case, that the family abandons them, or there is no family, or it's a court-appointed guardian, or there is no guardian.
That's what this case is?
Many of the times that is the case. In this case, there is no other supports.
Okay, thank you.
Any other questions? All right, seeing none, there's motion and support on the floor. All in favor signify by saying aye.
Aye.
All opposed? All right. Thank you very much. All right, next up we have a few policy updates. First is updated CMH MCO policy 9-520, recipient requests to appeal findings.
I move to approve.
Motion by Jones, support by Marilyn. Floor is
Hi.
yours.
Good evening. So the first one is 9-520, which I think Mark Mischel reviewed with you at your appeals meeting, your rights appeals committee meeting. And so I believe that you've already gone over it. It's an update because the CMHSP contract requires the update. And so that's why it's being updated in a nutshell.
Joan?
And as chair of recipient rights, we all approved it then.
Okay.
So thank you.
Thank you.
Thank you, Joan. There's a motion and support on the floor. All in favor signify by saying aye. Aye. All opposed? All right, that one passes. Next is policy 6-001, release of confidential information general. Take a motion to approve. Motion by Lou.
Support.
Support by Joan.
So this one was also reviewed with you at your committee meeting, and it's an update based on the update to the mental health code, which allows for the release of information without the consumer consent for care coordination purposes and for treatment purposes. And that's the only update to the policy.
Any questions? I already have motion and support. Yeah. Any questions? All right, seeing none, all in favor signify by saying aye.
Aye.
All opposed? All right, that one passes. Next is 5-001, accessibility. Need a motion to approve.
Move to approve.
Motion by Marilyn, support by Kathy. Go ahead.
So this is an update based on compliance with the Medicaid managed care final rule in section 1557 of the Affordable Care Act. We put before you an initial policy last year, which was approved, and this is just an enhancement of it. So it's updated to be more comprehensive, and it's focusing on identifying and assisting individuals with both sensory or communication impairments. There's many new definitions. There's some updated definitions. We're now including the notice of non-discrimination to all consumers, and it will be attached to all substantive documents that they receive. And the notice was developed by the state, and it's attempting to communicate with our consumers in an understandable way that will benefit them. The procedure section outlines specifically how we're using the notice and as well how we're using the taglines, because we now have taglines in 15 different languages, which are the prevalent languages in our area, that we need to provide to them.
Any questions? All right, seeing none, there's motion and support. All in favor signify by saying aye.
Aye.
All opposed? All right, that one passes. Next is policy 5-002, cultural and linguistic competency language assistance services. Take a motion.
Support.
Motion by Kathy, support by Brian.
So this is an update along the same lines as the previous one to comply with the Medicaid Managed Care Final Rule and also Section 1557 of the Affordable Care Act. And it more thoroughly outlines our compliance with Section 1557. It includes the development of a language access plan that will help us to demonstrate to the Federal Department of Health and Human Services how we are engaging our consumers in a meaningful way when they require assistance.
I have a question. So on a couple of these on, let's say M, O, and P, they don't say updated, but you said that this one is an update. Are these all updates to current policies, or is this one a new?
This is an update to a current policy.
Okay.
There's a lot of new information, but it is an update to a current policy.
Okay, thank you.
You're welcome.
Any other, Joan?
Yeah. Could you tell me how this system works when somebody comes in and needs an interpreter? What do? Get out on the phone?
Yeah, we
You
have.
have a list.
Well, we've contracted with a company called Bromberg, and they provide the interpretive and translation services for us. And so what this will do is it will help funnel the point of contact through one particular person so that he can make contact with that company and get those services in place for that individual.
Okay.
And it will be an administrative PHP level individual, so who will be able to assist everybody.
And it can happen just like that because if they come in.
Yes.
Okay, thank you.
You're welcome.
Any
Thank
other
you, Mr.
questions?
Chair.
All right, seeing none, we have motion and support. All in favor signify by saying aye. Aye. All opposed? All right, that one passes. Next is 3-030, procurement of specialized residential facilities. Take a motion to approve. Motion by Joan.
Support.
Support from Chris.
So this is an update to the procurement process, the RFP process for the group homes. And it's in order to comply with federal law and also the Michigan Medicaid Provider Manual, as well as an update to include our ethics ordinance. There was a typo that referenced the SUD Advisory Board, which has been changed to the Oversight Policy Board, in case anybody caught that. And it maintains the procurement by non-competitive proposal process, but it will additionally require a written analysis. So if we bring to you a motion like you just heard, it will include the analysis of why we're using that process.
Any questions? All right, we have a motion and support. All in favor signify by saying aye.
Aye.
Aye. All opposed? All right, that one passes. Next is 10-015, retention and disposal of non-clinical records. I'll take a motion to approve.
Move to.
Motion from Brian, support from Joan.
Yeah.
All right.
So the Medicaid Managed Care Final Rule updated the record retention requirements for quite a few different pieces of information to 10 years. So now, for example, the enrollee grievance and appeal records, there's a 10-year retention requirement. Encounter data, there's a 10-year retention requirement. A lot of financial information that the state uses to build the capitation rate, there's now a 10-year retention requirement. So it's in order to comply with that, the Medicaid Managed Care Final Rule, and retain that information in the event that it was requested.
Any questions on this one or comments? Brian?
Is that going to be put in a data system that's on-site and off-site? How are we going to hold the records?
Right. Well, generally, they're all electronic, so they're in our electronic system.
But it also goes to the backup system?
Everything's backed up. IT backs everything up.
Okay.
I don't know the particulars on that.
Okay. Thank you.
You're welcome. Sorry. I know what the requirement is, though.
All right. Thank you.
Any other questions? All right, seeing none, we have a motion and support. All in favor signify by saying aye.
Aye.
Aye. All opposed? That one passes as well. Last but not least, 5-003 grievances alleging discrimination, section 1557 compliance. I'll take a motion to approve.
Motion to approve.
Motion by Chris, support by Brian.
So this is a new policy, and it is in order to comply, again, with Section 1557 of the Affordable Care Act. And it establishes an internal grievance process for consumers to try and provide them a prompt and equitable solution if they have a grievance involving discrimination surrounding race or color, national origin, sex, age, or disability. And it also designates a Section 1557 coordinator. And so now we have a person who will engage in the investigative process and render written decisions if there is a grievance that's filed. Any questions?
Any questions? Joan?
So it won't go in front of any board, or?
It would not go in front of the board. It would go to the deputy director for review if the person was dissatisfied, if the consumer was dissatisfied with the finding. They also have the opportunity to file a grievance with the Federal Department of Health and Human Services.
Okay, so there is a cover.
Yes.
Thank you.
You're welcome.
Any other questions? All right, seeing none, we have a motion and support. All in favor signify by saying aye.
Aye.
All opposed? Passes.
Thank you.
Thank you. All right, next up, receive and file Medicaid funding 2018. Do you want to discuss that?
Yep, sure.
Motion by Joan. Support from Brian. John?
Thank you. I thought it would be a good idea to run this through you real quick. We're already into January 10th here of 2018. So it's a receive and file, and if you just give me a minute, I'm going to run through it for the benefit of all. That the action that in the process moving forward to look at our Medicaid funding, I just bulleted it. Macomb County Community Mental Health Board pursuit of adequate Medicaid funds for adults presenting with severe mental illness, those children with serious emotional disturbances, those adults and children having intellectual developmental disabilities, and those individuals having substance use disorders in Macomb County. Macomb County CMH Board and Administration recognition of the necessity to manage the PIHP Medicaid health plan contract with the Michigan Department of Health and Human Services and to ensure its contract requirement of having internal services funds protections. MCCMH responsibility for the assurance of medically necessary behavioral health services to all of those enrolled and eligible in Macomb County. Macomb County CMH pursuit of an added $7.5 million in the surplus funds in 2018. The Macomb County CMH letter forwarded to the Speaker of the House and dated January 2nd, 2018. That's attached. Macomb County CMH intent to educate the Macomb House and Senate delegation on the importance of adequate Medicaid funding for the people in Macomb County. Macomb County CMH intent to hold a legislative engagement, a breakfast-like meeting on the morning of February 16th. We can discuss that for the above noted purposes. For Macomb County CMH continued pursuit of these $7.5 million in funds early in 2018 and during the time of the 2019 budget development. In Macomb County CMH intent to hold a public hearing in March or to be determined for consumer network provider stakeholder community participation in need and understanding for education. And so what you have attached, and we've talked about for a while, is the letter to the Speaker of the House that I wrote and dated January 2nd. I referred to the June letter that we sent to them. And so as a point of reference, when he read the letter, he could go back to the June letter. It was clear and cut, into the extent that we received $5 million. We're asking for another $7.5 million. To the interest of the board before, there was some Medicaid bulletin information and language that come out that spoke to home and community-based services and offering consumers opportunity to live in the least restrictive environment and be community included. I included that language. Also that we need to educate the House and the Senate delegates of Macomb. So I think we should bring them together on February 16th. That's a Friday, just about a year to date when we brought them together last time. Invite them in, and at that point in time, I think we need to energize the discussion why it is that we need the $7.5 million remaining, and re-educate the legislature on the House and the Senate on the Macomb side, why it is we need those funds, to be able to talk about the Internal Services Fund, so we have those monies available, and not as so much as that we have to write a risk mitigation strategy and be at risk of not meeting that risk mitigation strategy and having to go to the county for relief, because that's the way the new contract is written. I think we also need to have a very quick, meaningful discussion about the DABs, the disabled, aged, and blind, that have turned to HMP. I talked to you and I gave you a full folder on this last week, that have gone to TANF and has resulted in $100 million of lost Medicaid revenue to all the PIHPs, and the department has taken the position, it's within your risk corridor, too bad. Macomb County has lost $6.2 million in Medicaid. So as we're trying to continue to reemploy staff to be able to meet Medicaid rates for CEO and some of the people that you spoke earlier, to be able to meet the acute psychiatric inpatient hospital rates that we met with this morning, who have put us on notice that you need to improve our rates, or else we continue to be challenged with being able to receive adequate Medicaid funding. And it should be of the foremost of importance for this entire board, whether we ask for a board or community mental health board of commissioner resolution that supports the awareness of the Medicaid loss again. We need to educate the representatives and the senators that we have lost in 16 and 17 because their DAB, when their Medicaid is re-enrolled, we talked about this last month, they're not re-enrolled in DAB. So you're not getting that $263 per member per month. They enroll them in HAB, or in HMP, which is about $50, or they enroll them in TANF, Temporary Assistance to Needy Families, which is about $16. We've lost $6.2 million in Macomb County. So it continues to be of importance to us. I don't know how to correct it individually, other than the department says, take it out of your risk corridor. We need to educate the legislature on how to make this right, because it's going to continue in 2018 and 2019. It's not stopping. And so therefore, I think there's an urgency of need to have that legislative breakfast. And if the board is agreeable to February 16th, I got the venue lined up. It would be over at the Community Care Center. We would talk about the $7.5 million. I will talk about the DAB gone HAB, HMP gone TANF. I will talk about the continued need to be able to provide medically necessary services to people. I sent an email to Tom Renwick, who's out of town this week, asking him, where's that infamous CLS report that everybody's waiting for? Because that's the first thing the legislature is going to want, is where's that CLS report, that engagement that was occurred? There are so many things that we can talk to that legislature about. We need to do it readily here, because they're going to start crafting that new budget. We need that $7.5 million, and we need the legislature's attention on what the department has turned a blind eye to, is for the PIHPs at large to suck up $100 million. So if the board's agreeable to that February 16th date around 9 o'clock in the morning or so, I'll do a PowerPoint presentation. We'll put together a presentation for the legislature to educate them what's going on. And we need to decide and strategize here amongst ourselves, how else do we approach that? I don't think we can, and I'm not suggesting we are complacent, but we can't be complacent in that much Medicaid loss. How do I make up an additional $6 million? And it's going on. It's going on today. Someone else today was DAB, and now is HMP. And someplace today we lost $2 per member per month. $213. We have thousands of people in Macomb County who are DAB or HMP or TANF. There's a big difference between $263 per member per month and $16 per member per month on how we are able to continue to provide Medicaid covered services. And then once we have that legislative breakfast, we really need to engage that legislature of ours to support and go through the speaker, as we've done before, and through your guidance and direction, to get that $7.5 million as a supplemental, because we're going to need that when we get to October 1st, which is coming up here pretty quick. We have about 9 months to close. And then I also think whatever other avenues we have available, should we go to the Board of Commissioners? We've done it before, and should we get a resolution of some type? We need to, I'll turn it over to you guys for some thoughts and ideas, but I do want to do it on February 16th, and then we need to energize the community too. So sometime in March, have a community forum. if we can get some of the House and Senate there to hear it from the community perspective, get the stakeholders there, and let's get the energy going.
Thank you, John. Any comments or questions on that? Brian and then Lou?
I have two questions. One, did the House Speaker answer the letter?
I sent that letter to the Speaker of the House, to the entire Senate, the House of Representatives, to my provider network, to all of my executive staff, senior staff, this CMH board, and I didn't hear from anybody.
Okay, that's what I was wondering.
But I'm interested in it.
Secondary, I think the legislation breakfast would be good, but I'm thinking of mine, it's election year too, and there's candidates that already come out and said they're running for certain positions. It might be a good idea to invite some of these candidates too, that are running for the positions.
Yeah, if we
to
know who
hear
they
what
are,
this-
give me a list, certainly, yeah. I think it's going to be important that we educate. What is there, 30 of the 50 House are leaving, 28 of the 38 Senate are leaving, and if a lot of them are new, we need to, and I've already mentioned this to the PHP directors too, we need to play offense here in 2019 when the HMOs are going to try to, move the legislature, the governor, and whatever the healthcare industry is going to offer up then. We need to be able to let them know again the value of the PHP long before they even get seated in office. We need to have first strike with the House and the Senate, the new members saying, here's what the PHP is all about and here's the value of the PHPs. So I agree, in the legislative breakfast or ahead of time, we need to educate them on the value of what we do.
Thank you.
Lou?
If you want to settle February 16th, I'll make the motion.
All right,
At
we
the
have-
time?
Said 9?
We did the last one at 9 o'clock. The last one was done at 9, so I do it at 9 o'clock.
Are we going to do it at 15 Mile Road,
Yeah,
or are we
same
going to
place.
do it somewhere else?
Community Care Center, I think that worked.
All right, 9 o'clock on the 16th of February legislative breakfast.
Yep.
All right, we have a motion and support. Joan, did you?
Well, I just wanted to say it's Chinese New Year celebration that day.
And I just want to say it's a Friday, and Mondays and Fridays are best for the state representatives and the
Yes.
Senate because they're not in Lansing. So I'm not opposed to that date either. All right, we have a motion and support on the floor. All in favor signify by saying aye. Aye. All opposed? All right, that's the date. Thanks, John.
And,
Nick, go ahead.
Yeah, just a question, John. As these people are being enrolled into the right or wrong programs, which is then determining the reimbursement rate, that's what I'm hearing you say, basically. Who does the enrollment? And this is obviously not just a Macomb County problem. This is a statewide problem. Right?
It's the CHAMP system. It's the
the
Department of Health and Human Services, or DHS CHAMP system, that does the enrollment. So when you come, so if you're a DAB person and your Medicaid enrollment is due the first of the month, you're no longer DAB. You're now enrolled in HMP.
I think the legislative breakfast is a good idea, but I also think we probably should have a smaller meeting with the two Macomb County legislators who sit on the Appropriations Committee, say of oversight, one Democrat, one Republican, kind of works out nice. They've been supportive of us in the past. But I think part of the problem with the legislature at this point, and you've acknowledged part of it, is that it turns over so fast it's sometimes difficult to get people educated. You got to re-educate them.
Mm-hmm.
But at this point, with the ones who have responsibility for oversight, it might be a good idea to sit down specifically with them privately so we could give them more of a detailed education, because they're the ones that need to do the work.
Mm-hmm.
In addition to the breakfast, I think the breakfast is a good idea. Can you give us a little report? I know the State Association is active on this issue as well. Can you just tell us what they're doing, because this isn't just our problem?
Right. The little, rewind the clock a little bit. The PHP directors, 9 of them got together and commissioned a study on the DAB loss, and I didn't go that direction. We already had AFIA on board with us, and we figured we'd just do it ourselves without having to turn over our financial data to there was a conflict of interest. The person who was working for Raymond is also a CFO in one of the other PIHPs, and that had a bad taste to me. So long short story is that the 9 PIHPs got together and commissioned Raymond to do their analysis. We used the same logic, and through our IT department and AFIA, our contractor, we did an analysis. We sent those, and they're on, if you go to the CMH box, they're in the CMH box. So the CMH Association, Community Mental Health Association, Bob Sheen and Company, composed an overview of what that DAB loss actually looked like. At that time, they were talking about $91,000 or $91 million, but I'm telling you, it's closer to $100 million. And they met with two of the PIHP spokespersons, Joe Sedlock out of the Region 5 and Brad Casemore, just due to geographic availability, met with the Board Association and a number of the House members I don't know their names specifically, but I can get that, to talk about the current concerns that are here, and the department was there, and it was a very contentious meeting. From what I'm hearing and the takeaway of that, I can give you some cliff notes that I have of it. Keep them to yourself because I wasn't there, but a very contentious meeting. And so it does sound like that the Board Association has continued to work with some House members, but I don't know the names of those specifically. But it's not going away right now, other than the department is not acquiescent to the point where they're going to modify the rates at this point in time. Should they modify the rates, it may be in 2019, but our rates are already certified. And so CMS certifies the rates, and it's not as though the state can come in and modify the rates. It's really not a rate issue as much as it is a payment issue. And so
you're confusing me because I thought the issue was a classification issue.
It is.
That you were talking about which program they were under changed the rate of the reimbursement. There's two issues. I'm trying to keep them straight in my mind. The overall Millman problem with determining what our Medicaid rate is,
yep,
and then which program they're in alters the reimbursement rate. That's not the same thing, is it? That's
no,
two different issues.
You're right. The revenue that we receive is, based on their enrollment. So everyone's going to get the $263 per member per month across the state. And that's, what is being compromised here, because they're not getting the $263, they're getting the $50 HMP. When it comes to our rates,
enrolled in Medicaid.
Yeah, our rates are something different. If they're reimbursing us for psychiatric inpatient or HAB or those types of service deliveries, our rates that is not the enrollment rate. Okay.
So that's what I'm saying. That as I'm understanding it, what you've got is you've got Medicaid reimbursement, that's over here, and then you've got a bunch of people who are Medicaid eligible who are not being enrolled in Medicaid, but being enrolled either in TANF or DAB or something else that provides a lesser reimbursement level.
Correct.
Okay.
So if I can, I don't know where I left off, and I want to over-embellish this. The other thing that's moving too, as you should know, is Healthy Michigan Plan is ending. The 4-year capacity to be an HMP, it started in 2013, and we talked about this last time. Come March and April now in 2018, those who got in an HMP, Healthy Michigan Plan 4 years ago, they got to get out. Can't stay in HMP. What's going to happen, and we all sat in on a webinar yesterday, about 10 to 15,000 people per month in the state of Michigan. We'll have a share of those too. They're going to go into My Marketplace. So if you're familiar with that, they're going to go into My Marketplace, which is going to not be Medicaid. It's going to be run through the department. It's going to be run through HMOs. It's going to be run through qualified health plans. And those consumers who are HMP will now go into My Marketplace. There are going to be some of those that are going to be medically fragile. And the people that we serve, if we authorize more than a few PIHP services, they're going to classify them as medically fragile. And Kimberly Cope and I had a lengthy discussion today, and she's spot on with the fact that your risk pool is made up all these people who aren't never going to penetrate our services. So if all those who are never going to penetrate our services, those HMPs go into the marketplace, okay, and we only get those that are medically fragile, we just liquidated our risk pool. So, the rate adjustment is going to be critical as well, too. So that's a moving piece that's going on, in April. Is a lot of people will no longer be on HMP. You're going to hear more and more about my marketplace. But that's a good time for legislative breakfast. And then a community forum, too. So you can expect that in March sometime. We'll bring everybody together so they can, be familiar with it.
Any other comments or questions on this item? All right, we have a motion and support to receive and file. All in favor signify by saying aye. Aye. All opposed? All right, next is the executive directive, January 2018.
This receive and file item 2, the backdrop on this, about 4 years ago when we started HMP, we used to have around $26 million in general fund dollars, and now we're operating with about $8 million in general fund. We've lost that much money over the course of time. We used to support a lot of consumers who were on spend down. We used to support a lot of consumers who were just general fund in nature. There was a time not too long ago you couldn't differentiate the Medicaid benefit from the general fund benefit from someone who's indigent. We offered them the same. We don't offer them that anymore. And as this executive directive has been the 4th edition of this to get it continually refined, the only thing that we're required to provide by the Michigan Mental Health Code, by our contract with the state, is emergency and crisis-related services. So on the bottom of page 1 there, this is the 4th edition, phase 4 of this directive, that those are the covered services that we're going to provide. And we put in there crisis services and peer-delivered services and recipient rights, just so it's really clear to everybody. We're not obligated to provide anything beyond that. That being said, we have a number of consumers who are on spend down that are in a group home. So we've had this discussion before. We can't, have them go to the curb for 3 days until they meet their spend down and come back. So those consumers, we continue to have to afford the cost through our GF dollars to meet their spend down. And so what we didn't want to do is put anybody at risk. And so anybody who's we use this classification as a protected code, anybody who's like in a group home or in a community living support that needs ongoing support, that we just don't abandon them. They also need psychiatry. They also need their medicine. They need to see their caseworker, because we're going to have them in a group home. We just can't let them completely decompensate. They need a person-centered plan. They need case management contacts. So all of those are general fund dollars that we're still having to put forward to the consumer. What we don't have to, you can bite your cheek on this one, what we don't have to provide is Clubhouse. If they're general fund, we're not obligated to provide, nor do we have the money for Clubhouse. We don't have the money for skill building services. We don't have the money for follow along services. We don't have the money for supported employment. I don't know where we get the GF dollars. We just don't have it. We don't have the money for respite care for a GF consumer. So the message throughout this, and everybody, we got all hands on deck working on this right now. The message out there in 2018, we're going to be all right. We're going to be all right as long as we continue to refine ourselves and act like, as much as we're a community mental services program, we're going to act like an insurance agency as well, too. You're not going to go and see your physician, because the first thing they're going to say, Mr. Saramontero, your insurance lapsed, and they're not going to let you be seen. And so we're all clinicians and people who support, persons with developmental disabilities and mental illnesses, and that's why we're all here. So we're going to be sensitive to the needs of the consumers and continue to be convicted and be sensitive to what they need in the way of services. That's what we're all about. We're also going to provide nothing less than medical necessity, because we're obligated to do it. We're not going to provide anything more than medical necessity because we can't afford it. It's not there. And we're not going to provide services to people who don't have the benefit available in their benefit plan. So if you're GF, you get this service. We'll help you get on Medicaid. We'll do what we can. This is what you get if you're a general fund consumer. You get emergency service because that's all the money we have. If you're Medicaid, we're going to help you remain on Medicaid. There's no opportunity to lapse on Medicaid. If a consumer lapses on Medicaid, that hurts all of us. That hurts the board, it hurts the administration, it hurts the caseworker. There's no room for people to lapse Medicaid dollars. And so if you're Medicaid, you're going to get a more enriched federal benefit, your federal entitlements based on the medical necessity. If you're general fund, you're just not going to get the services that you think you should get. So I bring this to the board, because you may get a phone call or two that someone says, hey, I used to go to skill building, 3 weeks ago, or I used to go to clubhouse because I'm general fund, and we're giving them a due process notice. We don't have the money to do that, and we're not obligated to do that. So that's what this executive directive, there are some changes in it, but if you read, and it's posted online, if you had the third division and the fourth division next to each other, you would see some of the changes in them, and I already spoke to them. But they're all posted online, and this is just a more continued finessing of what we can afford in the way of a general fund benefit. And we're continue to remain compliant with the mental health code and our contract in doing so. So I wanted the board to be aware of it.
Need a motion to receive and file, and then we can discuss.
Oh.
Motion
Support.
from Kathy, support from Joan. Joan?
You're talking about clubhouse. You mean they have to pay to go there?
The two things that are going on with clubhouse, one is really cool, and one of them, if you're just straight general fund, you can't go there. You can't go to clubhouse, and because a consumer has the ability to pay, they're prohibited from paying themselves. It's kind of a catch-22 that we can't make a patient pay or a person pay for more than what their ability to pay is. So on the general fund side, clubhouse isn't covered. It's not covered any place in the state of Michigan. Skill building is not covered any place. Nobody's covering those services anymore. But if a consumer comes in and their ability to pay, let's say an outpatient therapy session, if their ability to pay is $8, then they pay $8. If we're having a financial crisis, we can't say, well, we're going to double and we're going to charge you $16. You can't do that. So our clubhouse program used to be about 60 people. Just the one that Bruce runs is about 60 people. And a bunch of us met a couple days ago. What the state is going to do, and we're down to about 30, I think, 25 or 30. So what the state is going to do is, because we raised the issue with the department saying, you have all these people who can no longer go to clubhouse. And so they're very quickly willing to support purchasing through their own block grant dollars the spend down for our consumers. So we are making a list. We're putting it together. It'll be done by Friday. And we're going to identify just the case number of all the consumers who either have gone to clubhouse and no longer can go because they have a spend down, or we think they could go to clubhouse if somebody could pay their spend down, or future consumers who may be able to go to clubhouse and may have a spend down. We're going to be able to tabulate case numbers only, send that to the department along with the anticipated cost for Macomb County PIHP, and all the other PIHPs are going to do that. And it's understandable at this point in time the department is going to purchase the spend down and reimburse us for the spend down cost for those consumers. And if that's the case, then Bruce's Clubhouse will go from 30 to 60 by April 1st. And then the Friendship House is probably, having the same challenges, will go from their 30 to 60. So there's a great opportunity to maybe service 50 or 60 more people who are on spend down, not the general fund people. And that's being driven right now through the department, which is good.
Yeah, yeah.
And if, anytime you want to talk further, have more clarification
Yeah.
on that, I would be more than willing to do it. But Bruce is running point on it with the finance director, and we're going to be able to identify all these people who should go to Clubhouse.
Well, he'll probably bring it up at our meeting.
So I think there's a lot of opportunity for us in 2018. And it doesn't rest with any one of us, it rests with all of us. So all of us need to be sensitive to Medicaid. It doesn't matter if it's myself or if it's, an administrator or if it's the staff. The staff, we've said time and time again, they go through school, they're a social worker, they want to start social work, and we tell them your foremost responsibility is you make sure your consumer remains on Medicaid. They go, I didn't go to school for that. That's your job. And if everybody does that, and the providers, Kathleen, and, some of, all of your folks that are coming through, if their Medicaid is going to lapse, everybody needs to be participatory on being able to ensure that Medicaid. And if we can change that culture and keep that moving, we're going to be fine. We're going to be fine because we're going to be able to be sensitive to consumers' needs, and we're going to give them what their benefit allows them to give them, and then we'll be fine. But we can't be frivolous and say, well, give them more than what we can. But I think we're good right now.
Any other questions? All right, seeing none, we have a motion and support to receive and file. All in favor signify by saying aye. Aye. All opposed? All right, next is receive and file for Children's Intensive Crisis Stabilization Services overview. Take a motion to receive and file.
Motion.
Motion by Chris, support by Brian.
The board wanted to continually receive updates on what we're doing out there in the community, and we've done those for the last couple months. Sheila Cote is the director of all of our internal operations. She has about 250 people report to her. Terry Nukugar has been around for a long, long time and has about 60 people report to her, and she does all kinds of specialty services for children. So the two of them today have a presentation for you.
So good evening. Thank you for taking the time to listen to our new exciting program that Terry Shap is going to handle. We're going to talk to you about our mobile crisis program for children. There is an increasing demand for inpatient psychiatric beds for children with limited availability. So we have children waiting in emergency rooms for psychiatric beds, sometimes for days. So the Department of Health and Human Services has amended the protocol for crisis stabilization services to include mobile outreach for children and families who are in crisis. This will involve staff going out into homes in an attempt to resolve the crisis before the child ends up in the emergency room. We have developed an intensive crisis mobile program for Macomb County to be operated out of Terry's program, Specialized Child and Family Services. Terry is going to, I think you received a PowerPoint presentation on the program. Terry's going to run through that with you and answer any questions that you might have. I'll be available to answer any questions as well. Thank you.
Good evening. Thank you all for being here and willing to listen to what we're doing next. We're very excited about it. It's a big undertaking, but like Sheila said, it's something that's greatly needed. We have children all the time sitting in an ER waiting for services, so we're hoping to add this that will decrease that extensively. So basically, mobile crisis, why we're adding it, is to make services more available to the family and to the children in their home. Like Sheila said, there is a shortage in psychiatric beds. This array of services that are needed for these kids is not readily available. So being able to respond mobily where they are, it's really like a 911 for mental health. We have 911 for medical emergencies. Now we will basically have a 911 for mental health emergencies. This is up and running in multiple states across the country, and it's been incredibly successful, and it has shown to greatly reduce the cost and time and stay of children in hospitals. A couple of the states that actually presented to us had actually literally closed down juvenile detention centers because they were able to keep kids out at such a large rate that they were no longer going into those. We'll be implementing the mobile crisis stabilization, and it's a kind of a combined with our current crisis stabilization program that we have. And SCFS, my department, already has an on-call program for our consumers. So this is basically just an add-on to that. We will be able to go mobile when a call comes in. Our first attempt will be to try to de-escalate that crisis over the phone. But if that is not able to happen and the family is still feeling they need an on-site visit that right then, we are able to go mobile Monday through Friday from 8:30 to 9 p.m. and on Saturday from 10 to 6. All other hours will still be covered by the on-call crisis line. Our phone numbers will still do the over-phone de-escalating, connecting with emergent services if necessary, and then follow up with them with a home site visit at the first available appointment the next morning. This also allows us to move kids more freely into our crisis stabilization program, which is an intensive 28-day service. where kids are seen, families are seen multiple times a week between their case management, psychiatric services, therapist, to come together in a family systems approach to work with the family to help them understand how to better regulate their child and help the child learn new skills in order to regulate. Where else do I want to go? The mobile crisis and crisis stabilization team will consist of a psychiatrist, master's level clinicians, a case manager, a nurse, a direct supervisor, and our parent support partner programs. On the mobile unit, when a team has to be deployed, a team consists of a master's level clinician and a parent support partner. And the idea behind that is the master's level clinician can immediately go in and begin to work with de-escalating that child, get the child and the family member separated, and while the master's level clinician is working with the child, the parent support partner, who's also trained and has been through these circumstances very personally in their own lives, can work with the family members to also help get them calmed down in a safer place. We can do some crisis planning to get through the evening and then follow back up the next day, reconnect them back with their current service provider if they have one, and if they don't have one, we would stay involved with them until we could get them connected to the proper services. The program is going to be available to any child in Macomb County that has Medicaid. Calls will come in via our access center or to our crisis line. We anticipate also not only getting calls from family homes, but also from the EDs around the area, as well as schools. We currently get a lot of calls right now from schools where our kids are attending. So we already have a lot of this in place with our schools, especially our center-based programs. So this will probably be just an extension in increasing that capacity even more. Any questions?
Any questions, Brian?
This one is there an age limit? Is it 18 or?
18. But there's an adults crisis stabilization program. It's not mobile at this time, but there is an adult crisis stabilization program available for people above 18.
So that would tie into it. So like if I had a child that was 26 but had a mind of an 8-year-old, that would be able to transfer over into this to have the people that are, no?
No. Or children's, yeah, we stop at 18 and transition off into adult services.
Okay. Thank you.
Any other questions or comments?
I have a couple. Go ahead.
Joan, go ahead.
So you're talking about mobile. So you're going to go out to them? They have to come to you?
No, we're going out to them. We go out to family homes all the time now. Now we'll be going out when they're calling and indicating it's an emergency and they need immediate help.
And all those people that you have on here are go out with you?
Yes. Well, no, I take it.
They're going to go out in teams, so there will be a master's level clinician and a parent support partner.
But we have psychiatric time dedicated just to this program and a nurse's time dedicated just to this program.
So about 3 people?
The team itself consists of about 5.
5.
Yeah.
Yes, I don't think you should go out to homes. At least have 2.
There will always be 2 people going.
That was going to be one of my questions. Can you describe for the board the safeguards that we have in place with iPads and Find My Phone apps and those types of things, and what your requirements are for your staff who go out into the community?
So, sure. We currently, through our program right now, the vast majority of the services we provide are in the home environment. And so we are oftentimes going into situations, even now, that are very tenuous. And so our staff in and of itself have a lot of training in how to deal with these situations, how to respond, how to react, what to look out for. But as John indicated, all of our staff are equipped with cell phones and iPads. And our program specifically has after-hours check-in requirements for our staff. Because we have to be available and to provide home visits when our children are available, we have to wait for them to get out of school. We have to wait for parents to get home from work. So consequently, a lot of our visits are taking place after business hours. So we have to have internal processes already in place in order to ensure that our staff are safe. The phones are all programmed with Find My Phone, Find My Friend. So if we can't get a hold of someone's not reaching back to us, we have a way to track down their phones. We also, we do call in for police support when necessary. We try to avoid that at all costs because it tends to just add more trauma to our kids. But we do know at last resort we do have to call that in.
Well, when you find abuse in the home, do you call that? Do you bring that up?
We're mandated reporters, so we are pretty consistently, I would say multiple times a week, filing CPS reports for abuse and neglect.
Yeah. Thank you. That sounds like a good program.
John, do you have more questions?
Since we have a little bit of time, two more things. One is I don't believe that we've been certified yet, but we're still waiting from the department.
The application has been submitted.
Yeah. And while you got the microphone there, the two of you, can you describe to the board that your efforts in pursuing adult mental health block grant dollars to the tune of maybe $100,000 and plus children's mental health block grant dollars to the tune of maybe $150,000 that you guys have been working on the last couple of days?
Yep. There's been a team of us sort of working on applying for 2 grants. One is for adults with mental illness for our crisis stabilization program. We're looking to enhance that program by adding case managers to the staffing so that they can assist individuals with applying for benefits, making sure they stay on Medicaid. One of the issues we have is that we have individuals who are general fund that qualify for crisis services. So they go into our crisis stabilization program and they get 28 days of intensive services. However, once they leave that program, they're no longer eligible because they have general fund. They don't have benefits. So one of the patterns that we see is these individuals, due to their mental illness, they have difficulty applying and following through with benefits. So by adding case managers to this team, they will be able to follow these individuals, help them apply for their benefits, and provide some continuity of care so that they don't end up back in their emergency room. So that's our proposal for the adults. Do you want to talk about the proposal for the children?
So the proposal for the children is to help support the new mobile and crisis stabilization program. It will provide funding to bring on additional parent support partners because our parent support capacity is pretty much to the top at this point. So it will bring on additional parent support partners to add to this team. It's also going to provide additional training and support services to my staff that are going to be providing this service. The mobile crisis is available to a child whether they have a serious emotional disturbance or a developmental disability and or autism. So the staff that are going out into these homes have to be very well versed in how to approach a child and a family based on the type of disability they're working with. A child with severe autism is going to require a very different way of de-escalation than a child with a serious emotional disturbance. So my staff have to be very familiar with how to interact and de-escalate a situation no matter what the diagnosis is. So a lot of this is going to also go to training. We've also talked about part of it is going to include the ability to purchase what I refer to as a toolkit. So each of my staff will be equipped with their own toolkit so that when they go into the home, they will have a variety of things at their disposal immediately to help them through that crisis, whether it be sensory type items, therapy, exercise bands, weighted vests, weighted blankets, fidget spinners, whatever it is they may need to help refocus that child at the time, maybe even refocus the parent at the time. And then we're also looking into additional safety and security measures. Maybe one of the things we looked at was a bracelet that they could just tap for emergency help. So those are the funds to help offset the mobile program.
So we just recently submitted our proposals for those grants. We're waiting to hear back from the department.
So the one is $100,000, right?
The adult is $100,000. The children's is $150,000 over the next year.
Yeah, good luck.
So, thank you.
Yes, good luck. What's the timeline for those grants?
So we're waiting for the application to be approved and signed off by the state. We are in the process right now of pulling our team together. I'm utilizing predominantly staff that I already have on site. So I have to do some shifting and rehiring and replacing some of, obviously, that staff in order for them to free up their time. And then we're meeting now pretty much a couple times a week to just lay out the groundwork, develop the internal processes and policies on what it's going to look like, how it's going to go, and our target date for it to begin to go live is March 1st.
It's quite the process, so good luck.
Yes, it is. Thank you very much.
Kathy and then Joan.
How will you get your referrals?
So any parent that is feeling that they are in crisis, the parent is the one that will determine the crisis, not the crisis center, not myself, not our access center. If a parent is feeling they're in crisis, they're the ones that are making that decision. Those calls will either hit the crisis line through Macomb County or our Macomb County Community Mental Health Access Center. They will do a quick triage to determine basically, do you live in Macomb County? So county of origin eligibility and funding eligibility, meaning Medicaid. And then from there, that call will be transitioned right over to our program.
Okay, so they really need to go through access or the crisis center first for the purpose of the screening.
We thought about that, picking a different number for them to call, but really, our consumers and our population have been trained to call the access center, the crisis center, so we thought that was the best avenue.
So you're looking to just serve existing consumers that we serve? Here, what I'm getting at is, could a police department call you if they receive a call?
We anticipate that police departments, hospital EDs, but the role of the crisis line or the access center will be first to determine if the child is on Medicaid or if the family's on Medicaid. And if they are, that's really the only thing that matters. If they're not open for services within community mental health, that does not matter. It's the funding source that matters for this, at least at this time.
Okay, so if there's some other referrals or other people wanting services besides the two you already said, it's possible, but they'd have to call through.
Correct.
Those two, the crisis center and access first. Okay, thank you.
Joan?
You're talking about block grants. Are they special block grants for the mental health? You know,
Yes.
every city, has a block grant.
They're specific to mental health dollars for adults and children.
Is there any way you can use other block grants? I wonder. I wonder about that. I don't see why we can't look at that for Crossroads. You know, Warren's got a block grant.
Yeah, the department usually sends us notification of opportunities, so I would think that would come across our desk if we saw one and we would
Okay,
apply for it.
I'll inquire tomorrow. Thank you.
Any other questions or comments? All right.
Thank
you
you.
very much. Have a motion and support to receive and file. All in favor signify by saying aye.
Aye.
All opposed? All right. It's been received and filed. Next is a resolution to pay tribute to Kathy Lancaster at the time of her retirement. Need a motion? Thanks, Joan. Motion by Joan. Support by Brian. Any discussion, comments, questions? All right, seeing none, all in favor signify by saying aye. Aye. All opposed? All right, Kathy can retire. Next up is other agenda items. Start with Kathy.
On our desk, we have this green page are we looking for a survey of what night we want, or what's the purpose of this being here? For the Metro Region dinner that's hosted by us?
Barb, is this, I'm going to defer to Barb. Are we looking for a date to host the Metro Region dinner meeting? Is that what this is about? Okay, so we need to, it's our turn in June to hold the Metro Region dinner meeting, and that's what the request is. You guys want to pick a date here?
June 19th.
June 19th?
The 19th, did I hear?
You heard the 19th, Lou. All right. Just like that, we have a motion and support for Tuesday, June 19th. All in favor signify by saying, well, Chris is looking at his calendar. All in favor signify by saying aye.
Aye.
All opposed? All right, we're going with Tuesday, June 19th. Man, I wish everything was that easy to schedule. Any other agenda items? Lou, did you have something? Okay, perfect. John, you have anything for us?
I'm not going to be at the full board meeting because I think I'm going to be down in a warmer climate. And there was some discussion earlier today in regards to a UBHC update. And so Jim is going to provide the board at the full board meeting with the UBHC update. If you have any specific questions or interest on what you're looking for, either let him know now or send him an email and let him know that. And also maybe some system reform. I think there was some discussion when we put together the strategic plan in February. I have a number of updates coming to you. The board my staff are putting them together now. So NCQA accreditation, I'm going to have an update on that. On the HCBS, I'm going to have an update. Jim is leading the charge on some system reform. And so, maybe Jim as a recommendation to do the UBHC and some system reform ideas for the full board. But just to let you know, I'll be thinking about you guys.
Thank you.
Thanks, John. Any other agenda items? All right, seeing none, we will move on to the hearing of the public. Anybody from the public wishing to speak? You have 5 minutes. Give us your name and address. We can't respond, but we can hear you out.
Good evening. My name is Jamie Peck. I live at 2261 Wadhams Road, Smiths Creek, Michigan. I am a program manager at Creative Empowerment Opportunities, Clinton Township location. And I know we're going through a lot of ups and downs this evening. I just wanted to take a moment to thank the board. Recently, there has been a 50-cent increase for our staff. And I just wanted to make that known that that is much appreciated from all of us to all of you. So that's all I needed. Thank you.
Thank you. Anybody else from the public wishing to speak? Going once, going twice. All right. Hearing of the public is closed. Take a motion to adjourn. Motion by Joan. Support from Brian. All in favor signify by saying aye.
Aye.
Aye. All opposed? We are adjourned.